So, in this part, we will discuss about the most common macular dystrophy, that is the Stargardt's disease and the fungus flavimaculatus. What is the epidemiology and the pathogenesis? Stargardt's disease is the most common macular dystrophy with an estimated incidence of 1 in 10,000, which accounts for approximately 7% of all the retinal dystrophies. Stargardt's disease is also known as Stargardt's macular dystrophy or fungus flavimaculatus. Stargardt's disease most commonly is inherited in an autosomal recessive manner caused by the mutation on an adenosine triphosphate binding cassette gene, that is ABCA4 gene, which has been localized to chromosome 1p 21 to 22. Only 60% of these patients have detectable mutation in ABCA4 gene. ABCA4 normally encodes for the protein involved in the visual cycle. Lipofuscin buildup in the subretinal space appears to be related to the mutation in ABCA4 and the resulting production of the dysfunctional protein. Lipofuscin is a complex mixture of bis-retinoid fluorophores that are amassed by the RPE cells. In the RPE, lipofuscin does not form as a result of the oxidative stress, unlike in the other cell types. Instead, it forms because of the non-enzymatic reaction of the vitamin A aldehyde in the photoreceptor cells, which is transferred to the RPE by the phagocytosis of the photoreceptor's outer segments. In the recessive Stargardt's and the ELOV4 retinal-related dystrophies, the formation of this lipofuscin is accelerated, leading to the cell death. Carrier parents are unaffected. Interestingly, mutations in this gene may play a role in other retinal diseases including ARMD, autosomal recessive RP, and autosomal recessive chondrodystrophy. These ABCA4 related dystrophies likely represent a spectrum of the phenotypes with the overlapping retinal changes, just as the Stargardt's disease itself exhibits a great variability in clinical expression. In addition to the recessive Stargardt's disease, there are other rarer forms inherited as dominant rather than recessive traits. Autosomal dominant Stargardt's disease is rarely due to different mutations of ELOVL4 gene, which codes for the photoreceptor specific membrane bound protein that plays a role in the long chain fatty acid biosynthesis. Several other retinal diseases mapped near to ELOVL4, including recessive retinitis pigmentosa, Leber's congenital amaurosis, dominant chondrodystrophy, North Carolina macular dystrophy, early onset dominant drusen, and progressive bifocal chorioretinal atrophy. What are the ocular manifestation and diagnosis? The phenotype variation of the mutations in the ABCA4 gene presents in many forms as described above. Stargardt's disease is the term to describe the macular dystrophy characterized by macular flecks that accumulate at the level of RPE, sometimes resulting in central macular atrophy early in life. Fungus flavimaculatus is caused by the mutation in the same gene, however, the phenotype was historically considered different, as these patients have the characteristic flecks distributed throughout the fungus and the onset is in adulthood. Stargardt's disease classically is marked by the accumulation of discrete pisiform flecks at the level of RPE. Early in the disease, the patient may have few flecks, but they often will develop more macular flecks along with the patches of characteristic central atrophy. Patients with fungus flavimaculatus have pisiform flecks more in the periphery retina, sparing the macula. Therefore, the fungus flavimaculatus patients tend to retain the central vision. Stargardt's patients, on the other hand, develop a macula with a beaten bronze appearance caused by the atrophic changes in the RPE. In addition, they also have a dark or the silent choroid on the FFA, which appears as a predominant retinal circulation against the hypofluorescent choroid. While this finding can be helpful in making the diagnosis, only up to 1/4 of the patients have a dark choroid. On angiography, the pisiform flecks do not stain. Autofluorescence can be helpful in showing the lipofuscin in the flecks and the atrophic area, which will show photoreceptor dysfunction. The ERG is normal early in the disease but may be reduced in the more advanced cases. Of note, The ERG findings do not directly correlate with the clinical findings. Also, EOG Arden ratio may also be mildly reduced when there are diffuse RPE changes. High resolution OCT can show atrophic changes in the photoreceptors and the RPE, and the lipofuscin deposits can be detected within the parafoveal RPE. Interestingly, these changes usually precede the occurrence of fundus abnormalities. The OCT can also help with the diagnosis and aid in determining the status of the photoreceptor layer in the macula, which is beneficial in the assessment of the central vision. What is the pathology of the Stargardts? Histologic studies reveal that the Stargardts patients have a buildup of lipofuscin-like pigment in the RPE. The mouse model, a knockout of ABCR minus of the Stargardt's disease, also has an accumulation of lipofuscin in the RPE. Specifically, the toxic bisretinoid, which is the N-retinylidene, N-retinyl ethanolamine. What is the toxic component? Bisretinoid, N-retinylidene, N-retinyl ethanolamine. That is the A2E protein buildup, suggesting its role in causing the disease. What is the treatment course and outcome of the Stargardt's disease? To date, there is no proven treatment for this disease. As ABC4 plays a role in the vitamin A processing in the visual cycle, additional vitamin A is suspected to make the disease worse. Therefore, all forms of saturated fatty acids, all forms of vitamin A supplements are discouraged for these patients. Polyunsaturated fatty acids such as docosahexaenoic acid, that is the DHA, have shown to reduce the toxicity of the E2E and is therefore recommended for the patients if they are autosomal dominant Stargardts. Gene therapy has recently been initiated for the Stargardts, and the StarGen has sponsored phase 1/2A dose escalation safety study of the subclinically injected gene therapy agent. Another clinical trial has been launched using the RP precursor cells derived from the embryonic stem cells injected subretinally for the patients with Stargardts. Advanced cell technology used the RPE cells derived from the human embryonic stem cells surgically implanted into the submacular space. This study shows that the first treated patient tolerated the treatment without adverse effects, and the patient with the Stargardts reported improved best corrected visual acuity, improved slightly from hand motions to 20 by 800. Saffron, MP4 and DHA are all being studied in additional clinical trials for the Stargardt's disease. Individual members of the families with the Stargardt's disease often display tremendous variability in presentation, course, and outcome. The visual prognosis ranges from 20 by 50 to 20 by 200 as determined by the extent of macular atrophy, depending mostly on the extent of the macular atrophy for both Stargardt's and the fundus flavimaculitis. CNV is rare but can worsen the prognosis if it occurs. So, fundus autofluorescence delineates a macular atrophy in the Stargardt's disease and allows accurate measurements of the atrophy. Color fundus of the right eye and the fundus autofluorescence should be compared. OCT will show central retinal thickening in the Stargardt's patients from the photoreceptor and the RPE cell loss.